show you here. Oh no, it's not here. I wanted to show you something like a virus infection. Maybe it's not here. Sorry. Okay, let's move on to the next one. Okay, this talk it's been a long day, and you've done very well to stay awake. And we finish on the last talk, which is holoprosencephaly. And we had an example of holoprosencephaly today. So if you look at holoprosencephaly in the first semester of pregnancy, there's alobar holoprosencephaly and semilobar. The lobar holoprosencephaly we cannot pick up in the first semester. It is not possible. Remember, there's no cadence septum pellucidum. And you cannot make a diagnosis of agenesis of the corpus callosum at 11 to 14 weeks. So, if we go to the one where we can make a diagnosis of alobar holoprosencephaly, I ask you the question now: what are the abnormalities that you see when you examine this baby's brain? 1 is the orbits are small. Now let me go to the big one. Number 1, the falx is missing. So normally, when you look at the brain, you see a falx and you see 2 choroids, and then you see the fluid of the lateral ventricle. In this baby, there's a single anterior monoventricle. There's no falx, and the choroids are very abnormal in appearance, shared across the midline. You see a normal aqueduct of Sylvius, and the distance between the aqueduct of Sylvius and the occipital bone is normal. Be careful, because quite frequently with holoprosencephaly, the baby also has spina bifida. And that's important because you need to give the patient folic acid in her next pregnancy, if she has spina bifida along with HB. You then look at the 4th ventricle, and you see the 4th ventricle is enlarged. Same as the baby this morning, with a big 4th ventricle. Tells me that this is holoprosencephaly related to either trisomy 13 or 18. Because if it's not trisomy 18 or 13, as Tring said earlier on, it's less likely to be microdeletions. It's more likely to be a single gene disorder of the SOX gene mutation. In this baby, you've got a dilated 4th ventricle. And then you come down as well, and you look at the eyes. In the normal eyes, you have an orbit that's this size and this size. And you should the distance between the 2 orbits is 1 orbit in a normal baby. In this baby, you have 1 orbit, 2 orbits, 3 orbits, 4 orbits distance between these 2. They're widely separated. So there are 2 problems: hypertelorism and microphthalmia. This baby has got holoprosencephaly, microcephaly, hypertelorism, and a dilated cerebral 4th ventricle. When you look at the fingers, you see there is polydactyly. In the baby this morning, had polydactyly of the feet. It tells you, and it also had tachycardia of 187. Tachycardia, polydactyly, and exactly the same findings. Tells me this baby has got trisomy 13. When you look at this baby, it also had bilateral cleft lip and cleft palate, dilated right atrium, and a fetal tachycardia. This is the baby from this morning. The other feature when we look at it is the very abnormal profile. When you look at the baby's profile, you have a reduction in the frontomaxillary angle. This is reduced. You get sloping of the forehead. And when you look on silhouette mode, you see there's a single anterior nostril of a proboscis. And in the same baby this morning, there was also a gap in the maxilla. The baby had a cleft in the hard palate. So these are the extra markers you look for. When you look at the brain, you see it's got a Z-shaped brain, which is normal in the first trimester. If you see a Z shape or kink in the brainstem like that at 20 weeks, you're looking at a single gene disorder, Zellinger syndrome, or any other syndrome. But this is normal for the first trimester, but you see that the intracranial translucency is increased, and the baby's got a dilated fourth ventricle. And when we went to look on a rendered image, we could see that the choroids were shared across the midline. This is the choroids, and this is the single anterior monoventricle. So this baby had all the features from this morning that were typical of holoprosencephaly relation to trisomy 13. In this case, you see this baby, you say, oh Simon, I know what the problem is here. The baby's got a big head. Do you think the baby's got a big head? No, I don't think a baby's got a big head. I think the baby has a small abdomen. It's got a very small abdomen. And when you look at the transverse section through the abdomen of the stomach and compare it to the head, it's completely different in size. The abdominal circumference is less than the first centile. When I see a picture of a baby who has a dilated fourth ventricle and an abdominal circumference less than the first centile and a thin placenta, it tells me that it's digyny triploidy, 69XXX. And these babies will have a low risk on NIPT. So it becomes very important to look for the markers of holoprosencephaly. In this baby, as you sweep down, you appreciate that there's a central cleft palate, which is typical in babies with holoprosencephaly. There's also an increased nuchal fluid. And same with the baby today, you can see the very abnormal profile with an increased nuchal translucency. This is a case from over 16 years ago in 2009. Semilobar holoprosencephaly is a much more difficult diagnosis. So here you have shared across the midline, interruption of the phalanx, but there's otherwise normal separation into right and left hemisphere with a normal fourth ventricle. This is a much, much more difficult diagnosis. So we come across the baby also has a cleft lip, cleft palate. And when we look at the rendered image, we see a sharing of the anterior horns across the midline, but normal separation of the lateral portions of the ventricles. When we look at the baby, at the same baby, we also recognize that there's no visible lateral ventricle, left ventricle, and there's severe tricuspid valve regurgitation. So this is a baby with semilobar holoprosencephaly with a hypoplastic left heart at 12 weeks of gestation. And when we look at the face, you can appreciate also there's a bilateral cleft lip and cleft palate. Oops. Semilobar holoprosencephaly showing the tricuspid valve regurgitation with a hypoplastic left heart. And similarly, when you look at the orbits, see there's hypertelorism with microphthalmia. Then there's the middle interhemispheric variant, which is a very rare form of holoprosencephaly. So when you look at this case, as you sweep across, you appreciate that anteriorly that there is an irregular phalanx, but there is a separation of the prosencephalon anteriorly, and there is a separation posteriorly. So the features of a middle interhemispheric variant are a parenchymal bridge anteriorly and posteriorly, a phalanx anteriorly and posteriorly, separate thalmi, but absent or dysgenic or thickened corpus callosum and the face is not involved, and there are no endocrine disorders. So here you see the phalanx here anteriorly and posteriorly, but now you appreciate when you look here, the thalami, there's separation at this point here, but some infusion anteriorly. This is a variation. But this again, semi-lobar and the middle interhemispheric variant are very difficult and challenging diagnosis to make in the first trimester of pregnancy. So, if holoprosencephaly is difficult in the first trimester, there are other signs that may help you, and I'll be very quick. One, you may find that the BPD is reduced. That may be your first clue. Two, you may find that there's sloping of the forehead, sloping backwards of the forehead, a reduction in the frontomaxillary fascia. The normal angle is around about 80 to 90. And here we have an angle of 45 degrees. But you don't need to measure. You can see that the profile is abnormal. I've already mentioned that. You may also see a proboscis. So if you look at this here, you see a little cystic lesion, which is a very abnormal appearance to the fetal nose. And this here, when you look at the nose, it looks large, but there's a single nasal cavity in a baby with holoprosencephaly. So you may pick that the first thing that's abnormal is the nose. And if you lose with transparency mode, you see a single central nostril cavity in this fetus, who's also got hypotelorism, microphthalmia. So these are additional markers which may help you. The first thing that you may see is an abnormal profile, abnormal sloping of the forehead, an abnormal appearance to the nose with a very flat forehead, and an axial imaging, a normal mandible, normal maxilla, no cleft, microphthalmia, and a proboscis. So looking at the face is a very important clue. What about the pericallosal artery? Yes, a snake under the skull I've described. This tells you that it is likely that the baby has got agenesis of the corpus callosum, but I cannot make a diagnosis of agenesis. And then I mentioned to you, we've recognized recently that the anterior communicating artery is absent in babies with holoprosencephaly, but we have not published this yet. We will be publishing this very soon. And I've mentioned about, and when you look at hypertelorism, this baby's got hypertelorism, but this baby's got hypotelorism. So you see the two tiny orbits here and here. So microphthalmia and hypotelorism, where this is microphthalmia with hypertelorism. So it may be hypo or hyper. Okay, is this baby normal or abnormal? This is more challenging, and I can understand somebody not making this diagnosis. But I'm hoping after today that you realize that this is abnormal. Because if you look at the choroids, the anterior monoventricle is difficult to see, but the phalanx making two separate choroids is abnormal. But the choroids should extend posteriorly. The choroids are in the anterior half. They do not extend posteriorly. That's a problem. In this case, at 13 weeks, the single anterior monoventricle is difficult to appreciate. So you could miss this diagnosis very easily. So sometimes it's challenging. You have, as you go back and forth, you've also got normal separation. This is your aqueduct of Sylvius. This is your mesencephalon, cerebral peduncles. This is your thalami. They're not fused. So it's a more subtle example. And this is where the anterior communicating artery becomes important. So I will finish up and say, once you see one abnormality, go looking for another. So this is a baby with a diaphragmatic hernia. where the heart is in the right hemithorax and the stomach is in the left, and also has holoprosencephaly. For holoprosencephaly, we are making this diagnosis much earlier because we can recognize, we can pick up a single anterior monoventricle as early as 9 weeks of gestation. In fact, we can pick it up even earlier. So this is 9 weeks and 6 days, single anterior monoventricle. In a patient with digynic triploidy, with a small abdominal circumference. And this is a 9-week embryo. You can see the tiny embryo, but when you do a transvaginal scan at 12 megahertz transducer, you can see the single anterior monoventricle, absence of the falx. So you can make a diagnosis of this very, very early. This is 9 weeks and 4 days, single anterior monoventricle, and the baby also has polyvalvular dysplasia with two flow motion, red, blue, in both the pulmonary artery and in the transverse aortic arch. Typical of trisomy 18 at 9 weeks and 4 days. This is a case of 9 weeks and 1 day with a dilated fourth ventricle, single anterior monoventricle, absence of the falx, in a baby who also has polydactyly of the hands, where the embryo measures 26 millimeters at 9 weeks and 2 days. And we published this in the American Journal. This is showing the single anterior monoventricle here, and this is showing the dilated fourth ventricle using 3D vocal, which produces a digital inversion cast of the fluid-filled structures in an embryo at 9 weeks. In this case, it also had a central cleft lip and cleft palate, and also had polydactyly. So it is possible to make these diagnoses even earlier in gestation. I'll finish up and summarize and say that for holoprosencephaly, it's a condition where you can make a diagnosis very early on in the pregnancy. With transvaginal examination, if you look for single monoventricle, absence of the falx, and sharing of the choroids, you will pick up 100% of the A lobars. Remember, always look at the face, look at the heart, and look at the hands. And remember that if the chromosomes come back normal, that you may need to consider investigating the parents, because they may have a form of the autosomal dominant form of holoprosencephaly, and you may see some features in the parent's face that make you explore exome sequencing in the parents, and then doing a chorion biopsy and exome sequencing in the next pregnancy. So when you go to work tomorrow morning, I say to you, if you do these 4 sections in every baby, you will not miss any cases of holoprosencephaly. Thank you very much for your attention. I would like to share just 2 last slides with you. Can you switch to this computer, please? So I brought up the slide to show you, if you want to take a picture of that. That's a picture which you may find very helpful to look at 20 weeks of gestation. Looking at 20 weeks of gestation, looking at the appearance of the Sylvian fissure. Then at 22 weeks of gestation at 45 degrees. And then at 24 weeks of gestation, it's here at 90 degrees. Then you get indentation or percolization anteriorly from the frontal lobe, and then the parietal lobe at 26. And then they percolization touch each other by 32 weeks. Just have that picture on your wall in your routine screening. And then there's one other slide I wanted to share with you, because a couple of you asked me, what is the prognosis for babies with agenesis of the corpus callosum? I spoke about being no data for the thin, the thick, and the short, but I do want to share with you the data on the prognosis. But as Trin said, it's extremely complicated when it comes to counselling parents with regard to outcomes in babies with brain malformation. And it's a combination of, number one, running imaging, number two, running genetic testing, and with regard to the brain, it is the organ that has got the highest yield with exome sequencing, wide exome sequencing, looking for single gene disorders, higher than any other organ system. And for the corpus callosum, 1/3 of babies with callosal abnormalities will have a single gene disorder. And therefore, the earlier you make this diagnosis, the more important it is to get a rapid exome sequencing performed. So the patient is not 30-something weeks when you give her the answer. But the last slide which I wanted to share with you is the outcomes for babies with agenesis of the corpus callosum. And this is a slide shared with me from Guillermo Azamendi. But here I want you to look at the isolated agenesis of the corpus callosum, which has got normal developmental outcome, mild percentage of 25% of them, and moderate to severe with 20% with mental impairment, speech delay, motor deficit episode, and autism. But I think these figures will change over time, particularly when we recognize that isolated was isolated in the days before exome sequencing. I think in the new world, with screening and making a diagnosis of isolated agenesis of the corpus callosum with normal exome sequencing, I think the prognosis for these babies we will probably find will be much better, that 55% of these will have a normal outcome. Thanks very much for your attention. Yeah, sure. So if there are any questions from anybody from the floor, any questions about anything we've discussed today, please feel free to ask any questions.
Một lần nữa cảm ơn ban tổ chức và cảm ơn thầy đã cho bài giảng rất là hay. Trong khi chờ đợi câu hỏi các bạn thì mình hỏi hai cái câu hỏi cũng khá là thường gặp. Tại vì thầy là một chuyên gia trong cái vấn đề về siêu âm thai sớm đó. Thì câu hỏi thứ nhất liên quan đến cái mặt marker của cái hố sao đó. Marker hố sao vào năm 2024 thì là Palladini có nói một cái marker hố sao đó là cái thanh của táo đốc bằng mặt, tức là choroid bar và câu hỏi thứ hai thì thầy không thấy là thầy đề cập vấn đề đó, thầy có thể giải thích theo một xíu. Vấn đề thứ hai là thầy nói là ở khoảng chừng 10 tuần, 1 tuần á, khi mà cắt ngang á, mình rất khó đánh giá được cái phần của hố sau. Nhưng mà khi mình cắt dọc á, theo cái mặt thân mình làm nhiều cái thai sớm á, siêu âm thai sớm ở đường âm đạo á, thì ở 10 tuần nếu mình cắt dọc á, thì mình đánh giá rất rõ 3 phần. Là phần là brainstem, phần cuốn não, phần thứ hai là phần là não thứ tư, rồi phần thứ ba là phần là hố sau, thì rất là rõ ràng. Và như vậy liều là các dòng như vậy ở bắt đầu qua từ 10 tuần mình đã có thể đánh giá những cái bất thường về của open spina bifida.
Okay, with the first question, the last question I will answer first. So with regard to making a diagnosis of spina bifida at 10 weeks of gestation using the head signs, the answer is no. They are of no value, and there is no data to show that looking at the aqueduct of Sylvius or the cerebral fourth ventricle is of value in making a diagnosis of spina bifida before 11 weeks of gestation. Our experience in making a diagnosis of spina bifida before 11 weeks is by direct visualization of the spine, either in cases of spina bifida that's isolated or part of the OIES complex. The reason I think why there's no data is because in every baby, when you look at 10 weeks of gestation, the aqueduct of Sylvius sits right juxtaposed to the occiput. And therefore it's of no value using that marker. Secondly, you need to be very careful about making false positive diagnosis, because the rhombencephalon, the future fourth ventricle, is actually quite large at 8, 9, and 10 weeks of gestation. So I would say, no, there's no data, and my personal experience of 15 years of doing 10-week scans of drawing blood before cell-free DNA, that I don't think there are reliable head signs for spina bifida. And now I'm trying to remember your first question. Oh yes, the choroid bar. So with regard to the choroids, Dario has written a number of papers with regard to the choroids. I mean, the choroid bar paper, in a sense, is just making the point that like the drawings that I showed you this morning, I showed you a drawing of the fourth ventricle and axial section, and then I showed you the inverted C. That's the choroid bar. So the choroid bar is just a band of the choroid that covers the fourth ventricle in the first trimester of pregnancy. It's a normal anatomical structure, which Dario has given the name the choroid bar. Separate to it is Dario has also published, both in the first and second trimester, on the location of the choroid and trying to predict whether it's Dandy-Walker malformation or Blake's patch cyst. But this is something in the first trimester that I don't find helpful today, maybe in the future. I think, yes, the aqueduct of Sylvius is the useful marker, because if you've got a dilated fourth ventricle and there's no aqueduct, I think it's likely to be Dandy-Walker. Whereas if you've got a dilated fourth ventricle and the aqueduct is normal or increase in size, it's likely to be Blake's patch. But still, we do not have enough data for that, for me to say to you tomorrow morning, if you go to work and you do a scan at 13 weeks and find a big fourth ventricle, you do chorion biopsy and there's no chromosome abnormality, you come back to me and say, Simon, I think the fourth ventricle is increased and there's no aqueduct, therefore it's Dandy-Walker. Or you come back to me and say, Simon, the fourth ventricle is dilated, normal chromosomes, and there's no aqueduct, this baby is Dandy-Walker. Or it's enlarged Blake's patch. I say to you, you don't have data to support that. It's only small numbers that have been published. Just because somebody publishes a paper of small numbers does not mean that I can go out tomorrow morning and start cancelling patients. I need a lot more data before I have certainty that that sonographic marker is synonymous with a certain detection. Yeah.
Thưa thầy, em xin một câu hỏi là khi là các sân tan đó, để thầy nói khảo sát các thành phần trong cái khảo sát cái vì tịch nước cuộc sống thể hợp đó, thì cái việc của mình đưa cái khảo sát thế nào và cái chung chia từ phía trước hoặc là mình từ phía sau để mình khảo sát các thành phần mình đánh giá cái tịch nước cuộc sống thể hợp thì là một khác nhau về cái khả năng tiên liệu mình phát hiện được.
It doesn't matter. It's you get if you look through the posterior cranial fossa, you are always going to get better detail of the fourth ventricle, the brainstem, the aqueduct, the cisterna magna. But even if you look through the anterior fontanelle, in the first trimester, I still think you're going to get very clear information. I think in the second trimester it becomes more important that you get the information with it posteriorly, but not in the first trimester. It's not critical, because the sutures are wide open. The metotic suture is huge at 12 or 13 weeks. It's tiny, you know, therefore it's wide open. And whether you go anteriorly or posteriorly, it's not an obstacle. It will be clearer posteriorly, but anteriorly it's also good. I would like to thank you all for staying here since 9 o'clock this morning to 5:15. In Australia, by 3 o'clock in the afternoon, everybody will go home. So I thank you for staying to listen to me, because it shows your dedication to imaging, and I wish you all the best in going forward, and I hope there are some messages today which you will find helpful. I would like to thank Dr. Hai and the team at 2U Hospital for looking after me so well. I would like to thank GE for their support in bringing me out here. I would like to thank Tim for looking after me for every time that I come out to Vietnam, for giving me personal attention to me and my wife. And I wish you all a safe journey home, and I look forward to seeing your happy faces again soon. Thank you very much.
Rồi lại thì sau một ngày làm việc là rất là tích cực, chúng ta được học rất là nhiều kiến thức của thầy nó truyền đạt đến chúng ta. Thì thay mặt đại diện bệnh viện Từ Dũ cũng như các bạn hôm nay xin gửi lời cảm ơn chân thành sâu sắc đến thầy. Nếu có cơ hội thì năm sau thầy đã tiếp tục ở Việt Nam để chia sẻ thêm những kiến thức rất là hữu ích. Bản thân em cảm thấy là rất là hữu ích khi mà làm thực hành, cho nên là em rất là mong năm tới thầy sẽ tiếp tục chia sẻ những kiến thức mới cho những cái bác sĩ tại Việt Nam có thể học hỏi thêm nhiều nữa. Rồi cuối cùng đều chúc thầy nhiều sức khỏe và nhiều niềm vui trong cuộc sống.
Xin cảm ơn bác sĩ Xuân Lan, và xin cảm ơn thay mặt tổ chức. Tôi xin cảm ơn hơn 400 quý đại biểu đã có mặt trong hội thảo ngày hôm nay. Kính chúc quý vị được sức khỏe, hạnh phúc và tiếp tục đồng hành cùng bệnh viện Từ Dũ trong những hoạt động khoa học sắp tới. Tôi xin kính mời